Our final presentation today is going to be on positioning Michigan as a national leader in interoperability and really taking a look at how Michigan and MiHIN specifically is performing in relation to the topics that we've discussed today. The first thing that we're going to discuss is Michigan and MiHIN's relationship to TEFCA. So one of the most frequent questions that we are asked is what our take on TEFCA is and if we are really ready for it. And the short answer is that yes, we are ready for it, but there are a lot of different reasons for that. First, TEFCA promotes this network of networks idea and model to kind of connect the entire nation together and really allow for the exchange of information. And this is a model that Michigan has been using within the state for quite some time now. So for us to kind of just project that onto a national scale and add in one additional layer, it won't be too much of an ask. It'll just kind of take us from a network of networks to a network of networks model, which sounds a lot more complicated than it is, but it is really quite streamlined. Second, we have been using the drafts of TEFCA, both the first draft and then this most recent iteration, to kind of determine our readiness for the national framework. And the new draft has two pieces of information that we've really been using. The first is the minimum required terms and conditions, which we heard about this morning, and the second is the MiHIN technical framework. And what these two pieces do is they really show us all of the requirements that would be necessary for a MiHIN to see how our current practices align on those, and if they don't, see how much effort it would cost us to make sure that they do align. But what we have determined so far in our analysis is that it would not require any sort of extraordinary effort for us to be aligned on those initiatives. Third, Michigan has successfully put in place a trusted legal framework for the exchange of healthcare information with participants from all over the state. So for those of you who are already connected to us legally, you're very familiar with our legal agreements and our structure, and you know how these agreements kind of set us up to share information across the state. So what we can do by already having kind of done this successfully already is we can not only participate in the national dialogue on what the common agreement could and should look like, but we can also kind of figure out how to coexist within the framework that they will create and kind of figure out how our trusted legal framework will support the common agreement moving forward. Lastly, Michigan does have the ability to support the exchange formats outlined in the draft, whether through the targeted query, the broadcast query, and the push or message delivery. So we can definitely take all of the use cases that we currently have in Michigan and then also make sure that we are interacting with other states and not just within our own. In terms of what is missing or what information we'd like to see moving forward or information that maybe we can provide more clarity on for our participants, I've outlined a few things on this slide. First, we'd want guidance either from the ONC or another entity, and I know that John provided some guidance for us this morning on this piece, but on how to deal with conflict of law situations. So this is a very common question that we get is, what is going to happen when one state requires consent to share specific pieces of information, but the other state does not? Is there going to be a kind of hard rule, like for example, saying that you must follow the consent laws of the sending facility, or you must follow the consent laws of the receiving facility or state? And trying to figure out how to resolve some of those conflicts is going to be a very important thing moving forward. Even if we don't see it from a piece of legislation or something concrete, even receiving some sort of guidance from either the ONC or another entity might be a very beneficial thing for us to see. We'd also like to hear clear roles and responsibilities for each of the players of TEFCA, whether that's going to be the RCE or the MiHIN or the participant member, or individual user, to kind of determine what responsibilities would each of us have, what kinds of things would we need to comply with, and would there be any sort of oversight responsibility for these new players. Third, there may be a benefit to discussing the conversation around voluntary participation and mandatory requirements once participation is occurring. So again, this is something that we've kind of already discussed this morning, so that's good that we already have a lot of clarity on that. But we have observed a little bit of confusion when these three pieces or these three rules have come out all at once, both the ONC rule, the CMS rule, and then the second draft of TEFCA. There's a lot of confusion around which pieces are voluntary, which pieces are mandatory, and which players that they actually apply to. So maybe this is something that we can parse out and make a little more clear for our participants moving forward. And then lastly, we might want some more information on how QHINs will be interacting with one another and the RCE once this framework is in place. So obviously TEFCA is going to be a huge opportunity for collaboration, but without kind of a clear pathway for collaboration and kind of a clear way to figure out how it could successfully be executed, it might leave the area a little bit murky. Michigan has always positioned itself as kind of a leader in the realm of behavioral health. MiHIN specifically has actively participated in the national dialogue surrounding the sharing of behavioral health information by really tracking with any current and future changes to legislation that has been happening. So that includes the RFI that came out on HIPAA earlier this year, as well as any changes to 42 CFR Part 2, and really making sure that we participate in the dialogue surrounding that and give our comments. We've also always tried to align the sharing of behavioral health information with the sharing of physical health information. So one thing that Michigan has done, which we mentioned a little bit earlier today, is that we've aligned our Michigan Mental Health Code with the HIPAA TPO exception by allowing for the sharing of treatment, payment, and coordination of care mental health information without patient consent. Not only has that been very beneficial and kind of moved Michigan forward as a state, but we've also been actively working on solutions for sharing behavioral health information, including the development of new and innovative cases to really make sure that providers are comfortable sharing this information. Kind of going hand in hand with that point, we've developed an innovative solution called the Electronic Consent Management Service, or ECMS. So one big topic of conversation in the behavioral health panel was if we are ready and if the technology is there to really put forth an electronic consent solution and put forth the solution that could kind of parse out different pieces of information. Sorry, let me just grab some water. And I know that the speakers on that panel said that we might not be there yet and that the technology is not there, even though consent to share exists. It's not really being deployed in a widespread solution. This is one area where I'm going to respectfully disagree. I think that there is a huge need for electronic consent, and MiHIN in particular has really been working on figuring out the most efficient way to build a consent solution that could be leveraged even in TEFCA moving forward. Our solution would essentially take tagged messages and then run them through a statewide system that could check and ensure that adequate consent is on file before routing message with specially protected information. So that would kind of be the first component. But then the second component would be this aspect of a consumer portal where patients could log on and actually dictate all of their consent preferences in real time. But in addition, click on each of those providers and then parse out which pieces of information that they want. We have kind of done this in a proof of concept way, so the technology is there. It's definitely something that we could do, but it's more of a conversation of, do providers want us to allow patients the ability to do this? And is there a harm if patients start going in and parsing out pieces of information to not share, that the provider then won't get the most comprehensive picture of that patient's care? And then lastly, we have and will continue to participate in patient and provider education to really ensure that individuals know when information can and cannot be shared. So really disseminating any knowledge that we have out to the state at large. Two topics that we discussed today are areas that hold a lot of promise for Michigan and areas that we can definitely continue to grow in. The first is going to be in the realm of artificial intelligence and machine learning and how we can leverage these technologies to build innovative solutions. One of the topics that we talked about at last year's Legal Summit was the bioethics of using predictive modeling software and how you could use that software to detect negative health outcomes before they occur. That is not something that we discussed this year, but solutions like that that are very innovative and could lead to widespread resolutions of these different conflicts that we're seeing in public health would be very beneficial. So we're definitely looking forward to hearing if you've heard of these same types of activities happening in other states or in other healthcare systems that we're just not aware of. And then the second topic that we talked about today is going to be the opioid epidemic. So the opioid epidemic is one that can truly benefit from a national sharing of information to really pinpoint what the key causes are and how we can develop specific solutions to really counteract those causes. So these slides outline just a few areas where Michigan is positioned as a leader and some areas where we can definitely continue to grow. But we really welcome your thoughts, and we'd love to open it up for any final questions or final sentiments that you would like to relay to us at this time. I know that Bharat was going to lead a session on our hot topic policy briefs, but we really just want to kind of combine this with the Q&A for this presentation and really just hear from the audience.
Tom Simmer, I guess MiHIN board is probably my hat for this question. When you're talking about sharing information, you mentioned the e-consent system having it tagged. And for information for treatment, payment, or operations, you don't need a consent. You mentioned that for behavioral health information, otherwise not restricted by other federal regulations, the information could go through the system tagged. What is the operational significance for the e-consent system of the law not being parallel to HIPAA in relation to care coordination versus operation? What falls within operations but not care coordination? Because I'm kind of interested in understanding how our law makes things different here in a sort of practical sense. Does that make sense?
Sure, yeah, that definitely makes sense. So let me try and answer a few different parts of that question. So the first part that I'll start is with the addition of the privacy tag that we would have. The significance of the privacy tag is that we need some sort of flag or some sort of notification when messages come from specially protected facilities, like let's say a Part 2 facility. And we would need to know that any information that came from that facility would be considered specially protected and that consent would be required. Without that flag, we wouldn't know to run that message through our statewide ECMS system and check for consent. So that is kind of why we would include it at that point. But you're completely correct. Like let's say for mental health information, for example, which is allowed to be shared for treatment, payment, and coordination of care, because that doesn't require a specific consent, that information would not necessarily need to be tagged before it came to us. That one, you could tag the information if you wanted, but that would be more of an insurance policy for the senders that are providing that information. We don't really require at that point, but it's just something to make them feel a little bit more safe before they share that information.
So operationally, the tag sits in the top level of the message, and as the message comes across, we're able to see what that tag looks like before you actually open the message, so that you have the ability to determine whether or not you've got a consent.
And then in terms of your next question, I think that is a question that we are often asking ourselves is what is the difference between healthcare operations under HIPAA and coordination of care under the Michigan Mental Health Code? The Michigan Mental Health Code never defines coordination of care. So we have really understood it to function in the exact same way as HIPAA healthcare operations, but there's a lot of hesitation in doing that, and providers are definitely not comfortable doing that, which is why that information is really staying siloed to a certain extent, why people are not increasing the amount of mental health information that they're really sharing even after that change in legislation, is because there hasn't been any more clarity on that.
Thank you very much.
Sure.
Yes.
So we actually have a client right now that has, thank you, Nicole Maggio from the New Jersey Innovation Institute. We have a client right now with the New Jersey Health Information Network that has concerns, to your point, about not sharing for the purpose of operations, but they do allow, with their participation agreement between two of their members, they allow for sharing of data and usage for care coordination, but not operations. So they're wondering how they can sort of step around that with us when we, as a health information network, want to be able to use that data for operations. So I don't know if you can just speak to that a little about, I don't know, best practice or.
Do you have a distinguishing language that distinguishes between the two definitions?
Yes.
And what would that be?
I don't know the specific language in the use, it's like in the use case exhibit, but their concern is, again, so it's actually like between a health information exchange and a hospital. They are, per their agreement, they can exchange based on care coordination and treatment, but they're not allowed to exchange, they're not allowed to share the hospital's data for purpose of operations.
I think it would come down to the definition, and it goes back to Dr. Simmer's question in terms of care coordination as opposed to operations. We as lawyers look at language and are very close, look very closely at that particular language and the definitions that are associated with that. And because the two terms are different, we have to wonder what those differences mean and how they're expressed. To the extent that you've got some definitions already that define what each of those mean, I think that you're going to be tied to those individually. Would you say it differently?
No, I definitely agree with that, but in terms of a solution, so one thing that I was saying with our last answer was this idea of privacy tags and how for the Michigan Mental Health Code, you don't have to tag the information, you are able to share it for treatment, payment, and coordination of care, but some providers feel more comfortable still having a tag on that information just because it would show that that information is restricted in a sense. One solution that we've been working on as we kind of develop this ECMS use case is the distinction between different privacy tags. For example, maybe having the term R on one message, and that would be for mental health information that fell under treatment, payment, and coordination of care, but having VR or very restricted on messages that actually require consent before. So you can still alert the receiver of the information that this is maybe mental health information that you want to be a little more careful with than just any physical health information under HIPAA, but you don't have to run it through a statewide system or check for consent as you would with like the VR code. So there definitely are solutions that exist. Sure.
There's a question here?
Yep. Greg Forsley, also with the MiHIN board, primary care physician, just like Dr. Simmer. But it kind of goes back to a little bit more of the complications of patients don't come in for one particular problem. Quite often it's a consolidated, combined visit that involves a lot of activities. And secondary to that, any voluntary compliance with putting a tag on a message in the world that I see in the health information technology, you don't get good compliance from your providers to do that unless it's an automated process. So raising those two wrinkles and complications, if I'm a primary care physician and I've seen the patient in the office for depression, for substance abuse, for marital discord, for congestive heart failure and high blood pressure, which would not be an unusual combination,
Sure.
What do I do with that?
Right. No, I think that that is definitely a very valid concern. One thing that we have tried to reiterate to different participants that send information to MiHIN is that it's not necessarily the type of information, but more where the information is coming from. So just because the information is substance use disorder information, that doesn't necessarily mean that it would automatically fall under 42 CFR Part 2. What would make it fall under 42 CFR Part 2 is the fact that it comes from a Part 2 facility, which is federally funded and deals primarily with substance use disorder treatment. So I think that when we're looking at these types of solutions, we really are targeting those facilities that we're not receiving any information at all from yet. But that is very different from receiving substance use disorder information from, let's say, Beaumont Health Systems, which is already sending this with their physical health information. They wouldn't need to parse out that information or necessarily separate it out or tag it. That information could still flow to us in the exact same way that the physical health information flowed to us, as long as they were not considered a Part 2 facility.